Hello everyone and welcome to Rad Chat. My name's Jo McNamara and I'm joined by fellow host Norman Joel Canderson.
Hi everyone.
So here we are live in the pod box at UKIO 25 and we're joined by not one but two guests.
Yeah.
Would you like to introduce yourselves please?
Yeah, so I'm Jeff. I'm a CT manager for a mobile company called Medneo. We specialise in MRI and CT scanners and mainly cardiac services really on the CT side. We do general work as well, but lots of cardiacs at the moment. Plenty of those going around.
And my name is Aoife Murphy. I'm regional lead radiographer at the same company and I specialise in doing radiographer-led cardiac CT service at Medneo.
Okay, so for us as therapeutic radiographers,
Yep.
we definitely don't have mobile
No.
racks.
No.
So tell us a little bit about why do diagnostics need mobile units?
So there's only a certain amount of scanners in the UK, isn't there? So we primarily go in and help with backlogs. So we only go into the NHS. There are other providers that do private hospitals as well. We focus mainly on the NHS. So if a hospital, for example, has a backlog of cardiac waiting lists or general oncology waiting lists, whatever they need, we'll go in for a fixed term contract and we will do as many of those scans as we can in that period of time, bring the waiting list down, and then we're off to the next one. We do also have longer term partnerships. So we've got a partnership with a hospital in the southwest and we've actually been there for 3 years now.
Right.
And we actually take patients from another hospital further up country under the same trust and scan their patients too. So we're just extra capacity really. There's only a certain amount of space for scanners, so we bring them in.
So why don't hospitals extend their kind of diagnostic services and just increase the space? Why necessarily do you have to have a mobile unit planted on that?
It's difficult, isn't it? Most hospitals, I guess, and we don't work in the NHS hospital space really, so I'm kind of guessing what they're doing. But there's only a limited amount of space. There's only a limited amount of money. Our services are staffed. So some hospitals do have their own mobile units as well, but they've only got the staff that they've got. So if they've got 2 CT scanners and they're fully staffed for 2 CT scanners, how do they then staff a mobile unit as well? So we come in with a complete service. It's staffed, we take in all the patients, we do all the post-processing, we do all of the scanning, and the patients go away again. The hospital then get their reports and their images and ready to go.
But I think in hospitals like the Southwest as well, they really struggle staffing wise. So capital equipment, they have loads of equipment, but they can't get the staff and they can't get the agency staff sometimes. So that's where we'll come in as like sometimes a short term or long term solution to help with that.
Yeah.
With the staff that you have then, how do they go and stay in the southwest if they're working there?
Yeah.
Do they travel in and out?
Yeah, so we put them up in hotels. So they can choose their own hotels, stay wherever they want. So our staff are all around the UK. It is a mobile role, so they accept the fact that they're going to travel for work. We do three days in a row, 12-hour shifts. So they will travel to, say for instance, one of my staff members lives in Somerset. She may go to High Wycombe or somewhere like that, do 3 days there, stay in a hotel, and then back home again afterwards. So it's not bad. It's all right. It's an all right life. Yeah. Well, I'm a manager, so I'm not. I used to do that. It's all good and well me saying it's really easy and great. But what's your reflection on it, Aoife?
I mean, I love travelling, getting to see different parts of the country, and it's really interesting. But I think also for me, I'd worked in the NHS for 7 years at one hospital trust, which I absolutely love. But then I changed location, so I need a new job. I thought I wanted to try out something a little bit different. And with Medneo and even mobile radiography in general, you get to use different types of equipment and see different protocols and ways of working.
Yeah.
So if you work in the one NHS hospital for your entire career, like that's absolutely great, you can achieve a lot. But I had a little part of me that felt like, I've only used one type of equipment and I've only seen one way of working and how to do things. And now I've seen loads and it's really interesting perspective-wise on how they do things in different areas.
That's a really, really important point, I think, because there is no standard way of scanning a patient. It's down to the radiologists and how they want to protocol it in that particular trust. And there's a massive variation for the same condition between different hospitals. It's really, really interesting.
Yeah.
So do you create your own protocols or do you rely on the trust that you're
So
employed by?
what we do is it's our equipment. So we've actually got Aquilium 1 Prism Edition scanners. So they're big 640 slice ones. We use them for our cardiac services and oncology services and things. We know how our equipment works. So what we don't do is take on the protocols from the trust necessarily, because what they're using on their Siemens scanner won't translate to a Canon scanner. We also use things like iodine flux calculations for our contrast, so we get perfect portal venous studies every time. And we don't do weight-based, so we don't do 1 mil per kilo at 3 mils per second, because it doesn't work for everybody. So we tailor our contrast to our patients. So what we will do though is we'll scan the patients, we'll give the trust what they need. So if they have volumes, axials, coronals, sagittals at 3 mils, that's what they'll get. So they can report their images, but we scan them the way that we scan. So we can guarantee the image quality.
Amazing. And we had the pleasure yesterday of coming and walking around the mobile unit.
Yes, did, yeah.
Which is really eerie, because you walk in and it just feels like you're in a hospital.
Yeah.
And yet you can then, when you pointed out, well, here are some seams that come up and collapse it. And for those listening, explain kind of what they would expect to see walking through in a mobile unit for us.
You're right, it's a strange thing, because you walk in from the outside and it's a trailer. So we've got 2 different types. We've got mobiles, which are the ones on wheels, and they go into hospital, the sides come out and expand, and then it's bigger on the inside. And we've got the new expandable unit upstairs, which is slightly different. It's on the floor and it's massive inside, absolutely huge. So you're right, you walk in and it's a clinical environment with a scanner there, and it's like walking into a scan room. And that's the point of it, really. We don't want it to be alien to patients. What we don't want them to think is that they're getting a lesser service by going onto a mobile unit or getting a less diagnostic scan or anything like that. Actually, most of the time they're getting a slightly better scan because we've got newer equipment, because it's on the mobile, so we have to refresh it. So actually they're getting a really good service, and we want them to have that familiarity of walking into hospital and being in that environment, and then they can get their confidence that it's going to be a good exam. What do you think?
Yeah, and it's a really nice environment for staff to work on as well. A lot of staff, they just said it didn't feel like you're in a hospital, and all the graphics and the artwork on the wall make it feel like slightly less clinical, less scary when they're coming in for a scan.
Light above the
we get lots of comments on that.
Isn't it?
Yeah.
That, that's what we try to do in the NHS, but it's great that you kind of replicate and make the environment
welcoming. Yeah.
So in terms of kind of the future, what, obviously the NHS is struggling, waiting times are going up, although there have been some reports it's dropping. I don't think the radiographers on the ground would necessarily say that, but what's the future for you guys?
We're actually doing a talk on cardiac waiting lists. We're here, we've done it for 3 days now. But 6-week waits are coming down, but in general, overall waiting lists are actually coming back up again, especially in the cardiac space. So for us, as Aoife mentioned, we rolled out our radiographer-led cardiac CT package. It basically means that we don't have a requirement for a cardiologist or radiologist to be there for the entire list. They can go and do their job. We give the beta blockers and GTN, we scan the patients, and then they can report them. So I think that's a massive thing. It's about radiographer training. There seems to be a shift in the technology to make the scanners do all of the scanning, and almost de-skilling the radiographers to a degree. We should be doing the opposite. They should be taking on more roles and being able to do more, and that's what we're trying to do, really, is empower the radiographers to take on more complicated examinations.
I always think that of AI. Everyone's like, oh no, is AI going to reduce the role of radiologists or radiographers? I'm like, no, it just means you can actually reduce your waiting times, but also means you can upskill and do other things and vary
Absolutely.
Which is exactly what we want to do at Medneo. And I think one of the fears that radiographers have when they move from the NHS to maybe a mobile provider traditionally was they think they're going to get de-skilled. But with us, you actually get upskilled. And I've got upskilled since I came to work at Medneo as well. Doing the radiographer-led CT service, we do traditionally the job of a radiologist or cardiologist on the mobile scanner. So they're free to report their scans and they can supervise other lists inside the hospital. And then for us, the radiographer role extension is really rewarding. So we're giving the GTN to patients and we're giving the beta blockers. We go through the patient safety questionnaire. We observe the patient and check their heart rate and do their OBS and do their recovery, and obviously decide on the scan parameters when we're scanning and the phase of the cardiac cycle that we would scan in, and sometimes that would normally be the cardiologist or radiologist that would decide that. So for us, it's been really rewarding that we can train our staff to do that, and then they tend to stay longer and really enjoy their job as well.
We want our staff to spend time with the patient as well. I hate the fact. I think CT to a degree is considered a conveyor belt, and you just get patients through as quickly as you can. I don't like that. The patient experience is key. We don't want patients to be scared of coming for a CT or feel like they're being rushed. They're going through, most of the time, they're going through a pretty horrible time. They're coming for an oncology scan. It may be the first scan to find out whether they've got cancer. It may be that they're going through chemotherapy and this is their follow-ups and things like that. It's a pretty horrible time for them. So we want our staff to spend time with them. And then we've got the Canon Aquilium Serve with the instincts on it. So Canon are saying it gives you 40% less processing time and things like that. Great, we'll give that back to the patients. We're not going to change our appointment times necessarily based on it, because at the moment everybody's rushing around trying to do everything. Brilliant, we'll give it back to the patients, spend time speaking to the patients and kind of give that experience back to them where they're not worried about coming for their scan, you know.
Brilliant. Well, thank you so much for joining us here at UKIO.
Pleasure, thank you.
If anyone's listening to this live, then absolutely go upstairs and out of the building, buy the little coffee truck, and
Yes.
they can come and speak to you.
And we've got a talk at 1 o'clock today?
1 p.m, yeah, scan B16, Medneo, so we'll be talking about radiography-led cardiac CT, more in-depth, so if anyone wants to come along, we'd love to talk to you about that.
And do you have any job vacancies at the moment?
We've always got vacancies, yeah. We've just taken on 2 new scanners, so we have to staff those scanners. So yeah, we're always happy to talk to people, especially if they're bringing loads of experience with them, then yeah, great.
Show me the money.
Yeah.
Thank you very much.
Lovely, thank you.
Thank you.